All right, hey everyone. So this is going to be a trial of a few minutes at first, just sort of getting some groundwork laid, and then we're going to move into the wet lab, and I'm going to sort of show some gross organs. So this is an idea thanks to our head and neck fellow Fuad, who I guess used to do autopsy organ teaching at Brown. Is that right?
Yes, we did it one time.
Okay. And so we thought that was an excellent idea. So we grabbed a tongue, a larynx, and a thyroid from an autopsy organ. And we're going to try sort of going over some stuff with that. So please give us your feedback on how you think the whole thing ends up going. All right. And if you guys have questions, pipe up or put them in the chat. So thank you guys for coming in person. I think it's important for you guys to see, live what's going on. So head and neck grossing, and all grossing for that matter, is for me really fun and extremely critical for patient care. So let's always, keep the fact that these are patients, these are our patients, and we want to do them right by treating their organs as if they were, our mother's organs. So, head and neck grossing, I like because it's generally very neat and tidy, but with challenging anatomic orientation. And so, yes, I understand that sometimes the anatomy and the anatomical terms can be complex and confusing, but that's what we're here for. We're here to go through it with you guys. The anatomic terminology may be obscure if you don't remember it from your, first year course in medical school. There is often challenges with three-dimensional orientation, with multiple tissue planes, with multiple tissue types. Don't forget, we have bone, we have muscle, we have fat, we have mucosa, we have teeth, we have eyes, right? We're not going to, of course, be dealing with the brain because that's neuro, but it all interacts. And everything really can be tackled with an appropriate strategy. So, the one thing I'll point out about orientation is that many of you have already experienced some incorrect tagging or suturing from the surgeons as they send, thyroids and other organs up. So, if something doesn't feel right to you or look right, or you're confused by an orientation or by a suture that a surgeon put on there, just ask, because you may be right, they may be wrong. Don't assume that you don't know anything. You do, you know something, and trust it. So where do we want to go for help? This of course applies to all specimen types. So of course there's the grossing manual, which has the most commonly encountered specimens. If there's something that you see frequently that is not on there, please let me know. For example, I can't remember if I ended up adding it recently or not, but we didn't have a template, or not a template, we didn't have instructions on removal of fat from bariatric surgery patients, and some of those haven't been weighed, right? And so one of the most important things on those is to actually weigh it, because these patients want to know how much they've lost. So I'm putting that out there for our next surgery meeting, but maybe that specimen isn't there, so I can add it, just as an example. Okay. On the website, which maybe already all of you have done, there is a subscription button. So the subscription button, I would ask you all to subscribe if you have not already. It will send out, we will send out blasts when there's a monthly meeting and we have new information to share. When there's a new specimen type that we add to the page. So it will notify you that those things are available. Just, I think you already know this, but the minutes from each of our monthly meetings are password protected. So you'll just have to type in the capital U, capital C, capital H, small path, and you'll get access to all that information. Okay, the Dragon templates are also available, but these are not substitutes for the manual. So you shouldn't use the manual without the template, and you shouldn't use the template without the manual. They go together hand in hand. If you see discrepancies between the manual and the template, let me know. We're not perfect. Sometimes one thing gets updated and the other doesn't. So we try to keep them, in accordance with each other. Of course, we always ask you to go to COPATH and or EPIC for things to look at before you start grossing. What did the patient have a biopsy, and what was the diagnosis? What am I dealing with? Carcinoma, melanoma, lymphoma. That's going to dictate your grossing. Op notes, what did they do? I know sometimes the operative notes aren't up when you're grossing a specimen, but if it's the next day, they often are. So this might help you understand what they did to the patient. And then of course, preoperative imaging, understand the location of the tumor as it pertains to the person, understand the anatomy. All of these are super important. I think most of you already know this by now, but the College of American Pathologists has synoptic reporting or cancer protocol templates that we use in our final reports for staging, they will be able to tell you what is important to look for and what to like think about when you're grossing, like size cutoffs. Some tumors have a size cutoff of 2, 4, 3, 6, 10 centimeters, right? So when you're around that measurement on your gross, those are the ones that you may want to pay a little bit of attention to. Is it 4 on the dot? Is it 3.9? Is it 4.1? Right? Because that's going to potentially change the stage for these people. So the other thing that the PAs, the American Association of Pathologist Assistants, have put together is their grossing guidelines that kind of hinge on both the staging guidelines as well as just general good tips for grossing. So you can ask, I think Rachel, et cetera, about how to sign up for this if you want. You can register as a lab guest without payment, and you can also have access to their guidelines if you'd like as another resource. Certainly people, right? So PAs, senior residents, the frozen section attending, right? That's always parked here in the CCD. And of course, the subspecialty attending and or fellow for whom or for whose service, right, you are grossing the case. So even if you're not going to be signing out that case, you're still grossing it for someone else to look at. And honestly, especially for head and neck, the more people that see the gross, the better, right? So if you, person number 1 triages it, person number 2 grosses it, person number 3 signs it out, and then attending number 4 and fellow number 5 sign it out, like that's 5 different people who've seen the thing and nobody, you know, has the full picture. So I would really, really, really urge you to call one of us, even if, you know, I look at it grossly and Mark signs it out or vice versa, like at least someone who has a global understanding of this clinical care for this patient, who sees the people at tumor board, you know, we should see it. So that, you know, the fellow is an excellent bridge because they basically end up, right, seeing all of our cases with us, presenting these patients at tumor board. So if attending is not available, please call a fellow. And this doesn't go just for head and neck. Honestly, this goes for all of the services. You should have been seeing these daily bigs emails to tell you what your grossing assignment is for the next day. So the best thing you can do to prepare is to review the gross manual for the type of specimen you're going to be cutting, even if you have, especially if you haven't seen it before. Look at the clinical history for that patient. And then, you know, give us a buzz, give us an email, give us a call. It's like, hey, I'm grossing a thyroid. The clinical history is this. Is there anything you want me to do outside of the normal realm for what I see on the website? Or I've never seen this before. I really would like you to come and look at it with me. You know, all of those reactions are completely reasonable, and we will be responding however is best. The camera situation, I think, is really great because we have the opportunity to transmit images essentially immediately, right? So as you all know, the MacroPath photos get transmitted directly to the M drive. And so if you take a picture at triage and say, okay, I need help with this, we can look at it immediately. We can also do live interactions with grossing. We could do Zoom on that MacroPath computer if you want to share a live specimen. Some people just do FaceTime, like, hey, I really want to show you this really quickly. And then, of course, if none of that works, like we come over and we look at the specimen with you. But don't forget there are these virtual ways to share gross cases, not just, you know, not just digital microscopy cases. You should really photograph every single tumor case in 3 ways, shapes, or forms, at least 2, if not 3. When you receive the specimen, you want to photograph it in the intact state for sort of overall overview and orientation. You then, if this is an organ that has a lumen, right, like a larynx, an esophagus, a gut, you want to photograph it, if applicable, after opening it, right, exposing the mucosal surface. And then certainly you will be serially sectioning through all specimens, whether or not they have a lumen or not, right? So you want to have photographs of the specimen slices, including the tumor, after serial sectioning to show the cut surface of the tumor. Because if you show me the outer surface of an organ, that's excellent for orientation, but I have no idea what the tumor looks like if you don't photograph the actual cut slices, right? So please just be mindful that there are these 3 ways in which photography should be used. I have a whole lecture on gross photography. It's on the M drive. I can give it to you again live in person if you want, but whenever I come over here and look at specimens with you, I always give you my, you know, spiel on photography. The like key points that I want to emphasize about gross photography are, of course, photograph abundantly, right? No one's going to fault you for taking too many pictures, but they may fault you for not taking any or not taking the appropriate ones. Zoom in as far as you can to eliminate as much background as possible. So if you have one tiny little piece of tissue on the screen, you know, remember these cameras zoom, right? So don't have all this background space because those are wasted pixels. Zoom in as far as you can to eliminate as much background as possible. If you're taking pictures of like multiple slices, again, for sort of orientation, that's all well and good, again, to show me where you sampled. But for one nice representative cross-section of tumor, maybe isolate that, zoom in, and then take that in addition to what you've already done. With the exception of some specimens that, you know, the services do not want bookended, like breast, like I think maybe the slices through the uterus, really most specimens should not be sort of bookended and butterfly. They should be sectioned completely through because you want to actually see what's in those couple of millimeters, right? If you don't open those few millimeters, you don't know what's going on at that edge of the tissue. So unless otherwise specified, please do completely section through and don't take butterfly or bookending pictures. Okay, so I for some reason when I was putting together this presentation, this Netflix documentary popped into my brain. Have you guys seen it? This The Pretend It's a City. It's like she's like walking through New York and like people are, you know, being tourists or whatever. And they're like, how do you read a map? Like, I don't know. And she's like, just pretend it's a city, right? Like, just pretend that you're in a city and that like, maybe you can read a map. And so it's funny. Anyway, my thing is pretend your photograph will be published. If you're like, I don't know, I'm just going to take this. Okay, always pretend that your photograph will be published because you don't know, right? You may not know the importance of some specimen or what the diagnosis is going to end up being, or whether it's going to be rare and publishable, or whether you're doing a project on something and you want to use it for a presentation, right? Like, so just always pretend your photograph will be published, and then you'll take really good photos if you always have that in mind. All right, that's just my little joke. Okay, so, you know, things to always keep in mind, of course, are things that dictate each other, right? Orientation and anatomy is going to dictate your gross staging and your gross sampling, which is going to dictate your inking and your margins, and they all work together, and none of them should be sort of considered in isolation. So, you know, without going into detail into every single specimen, I think it's important to just sort of keep in the context of how does something three-dimensional translate to something two-dimensional. And so always think about what your sections will look like on the slide. And I know that that's hard when you're first starting out, but as you start seeing things during sign out, you'll start to understand. What would you like to see from that specimen on the slide? How do you want it to look? And start to cut backwards that way, right? You have about a 2 by 1 centimeter space to fill in this cassette, and, you know, fill it generously. Of course, don't stuff it in there like a sausage, right? But you can fill this cassette pretty decently in space. Because if you have like a big, you know, prostate or bladder or something, and we see like a tiny little, unless it's like a margin, right? If you see a tiny little shape of tissue, you're like, well, why can't I just see a nice big slice of it? Like, you have a whole organ, right? Pretend like you're wanting to see that whole organ on the slide and put as much of it as you can in the cassette without stuffing it like a sausage. And make sure your slices are thin, but not too thin. So find the happy medium. So if the slices are too thick, right, they're not going to fix, and you're going to get weird like cassette marks from them being squished in there. And if they're too thin, histology has a hard time embedding them flat, and so they get a little bit kind of crooked, and then you end up losing tissue as they try to face the block. So again, happy medium of size and of thickness. Okay. So the head and neck specimen types that we're going to deal with over the course of your, you know, education are going to be the endocrine organs like thyroid and parathyroid, are going to be the mucosal sites, including the oral cavity like the tongue, the tonsil, the larynx as well. Other glands like the salivary gland. We'll be dealing a lot with neck dissections, and then sometimes complex anatomical sites like mandible, maxilla, ear, temporal bone. So, you know, every single one of these is different, okay? So please don't try this at home on your own unless you're very experienced. Always, always, always just call us. We are more than happy to come and look at it and discuss the sections that need to be taken. And not all of them need to be processed the same, you know? If they're big, thick pieces of mandible or really thin, like friable pieces, you know, the way that we section those and process them is gonna be different. So now it's time for our live wet demo. So does anybody have questions before we move on to that? That's just sort of a global introduction. Okay, so what for those who are remote, Heather is going to, why don't you try, can you try just sharing your, I'll pin your screen. So she is going to, all right, there we go. All right, so you need to maybe pin and, oh, no, actually, I want to spotlight you for everyone. Spotlight for everyone. All right, I'm going to mute myself here. We're going to go into the other room. If you can just change the aspect ratio to horizontal. Yeah, I think that's going to be cool. Okay. All right, so everybody out there in the virtual world can see and hear.
I don't know if you can hear me, but yes.
Okay,
Okay.
I got a confirmation.
Cool, thank you. All right, so if you ever do have an autopsy, let's just start there, where you need to retrieve tongue intact, or for that matter, if you have some lesion in the like nasopharynx that you don't know how to get to, there are two things we can help you with. We can help you retrieve the tongue by pulling it through the neck, and we can help you retrieve some nasopharyngeal tissues by opening up the base of the skull and getting out and getting into the nasopharynx. So don't think that those sites are inaccessible to you, even though we don't normally take them during autopsy. We can get them. Just call us if you need us. Okay, that's my caveat number one. Caveat number two, you may want, I don't know, you may want to come closer.
Yeah.
You guys too, don't be shy. I know, I'm sorry, I can't wear my mask. So you're just so we have here basically the entire intact tongue with a couple of nicks in it, but no worries. We have the epiglottis as part of the larynx, and then there we go. So this is the posterior side with the tongue. This is the anterior side with the thyroid gland on either side, and of course the undersurface of the tongue, which we had to cut. So excuse me, it's a little raggedy. So ventral surface of tongue, dorsal surface of tongue, anterior side of the neck, posterior side of the neck, larynx. Oh, we even have a little, yes, we do, right? We have two lumens. We even have a little bit of lumen of the esophagus here. So this is going to be helpful for us to understand our normal anatomy. So let me just poke through here. So yeah, cool. So, you know, there are airways and there are foodways, and there are some that do both, right? So the lumen of the air, right, larynx / trachea, is anterior, right, to the lumen of the food, which is esophagus. And so you remember conceptually, the esophagus is in continuity with the pharynx, right? So the pharynx is basically the space that's either behind the larynx, behind the tongue, or behind the nose, okay? Which I think we talked about in our histology lecture. So technically, this part of the esophagus that's right behind the larynx is the laryngopharynx or the hypopharynx. The esophagus starts at the constrictor
which is I think at the level of like C6 vertebra, or the cricoid. So that's approximately where the esophagus begins and the hypopharynx ends. Make sense? Okay. The thing that I think is really nice to see here is how the larynx interacts with the tongue, because on laryngectomies, we don't always get this, right? They sort of cut here and we don't get to see this connection. But here you're actually, this is really nice. You get to see the anterior portion of the tongue and these small little papillae here, which are the circumvallate papillae. They're almost like in a V shape. So those separate the anterior tongue from the base of tongue. If you guys want to come over behind me too, that's fine. Just please stand wherever you think you can see. So behind this V-shaped row of circumvallate papillae, that's the base of tongue or the lingual tonsil. Okay, so this now is part of your, what site is the base of tongue in? The oropharynx. Yep. So the base of tongue, right? The tonsils and the adenoids are in the oropharynx. So here you're in the anterior mouth, here you're in the oropharynx. Okay, then this is the part that we don't often see. So this little kind of connection between the anterior epiglottis and the base of tongue, on either side of that connection, these are the valleculae. All right, so this is where the bolus of food like rolls, it rolls into the valleculum, it pushes the epiglottis down, and it allows the food to go into the food way, right, as opposed to the airway. So when we talk about the space of the vallecula on laryngectomies, for example, that's what that actually is in real life with a little kind of frenulum there, okay? And then the epiglottis. So the epiglottis is bendy. So what kind of cartilage is it made out of? Elastic cartilage, exactly. So just like your ear, your epiglottis is bendy, it's made out of elastic cartilage. The rest of the cartilages of the larynx are made out of hyaline cartilage. Awesome. Okay, so what do? Let's open the esophagus. Let's see what we see. All right. If I'm going too slow or whatever, just stop me. You know what? I'm gonna go from the bottom. What time is it? Okay, perfect.
I think it-
Okay, cool. So esophagus, right, should have squamous mucosa. And, oh, this is also great. So we're gonna go through anatomy here. So when we open up this site, right, technically, this is the laryngopharynx or the hypopharynx, okay? At the constrictor, it becomes the esophagus, okay? So right now, we're in the hypopharynx. Does anybody remember these spaces here that are on either side of the larynx within the hypopharynx? Again, food's gonna roll over here, food's gonna roll in here and then roll down. What are these two spaces on either side? Yes, piriform sinus. So piriform meaning sort of, you know, pear-shaped. I don't know if this is pear-shaped, but we don't, again, this is not something we generally see on a laryngectomy because it's been cut off and, you know, the pharynx is now no longer in the patient. But yes, these two spaces on either side are the piriform sinus. We have mucosa here covering the cartilages of the larynx. So I know that you can't feel it right now, but this is the cricoid cartilage that is right underneath that mucosa, okay? These two little nubbins of cartilage are the which? Anyone? Starts with an A.
Arytenoids.
Arytenoids, exactly. So as you go from the epiglottis to the little arytenoids, this ridge here is called the epiglottic fold, exactly. So it bridges the arytenoid and the epiglottis. So epiglottic fold, arytenoids, cricoid, piriform sinus. Awesome. That's good anatomy there. That's lovely. Okay. Let's go, what did we do? Go on the other side to the thyroid? Sure. So in this case, I don't think, we don't have the hyoid. No, we don't have the hyoid. Oh, yes, we do. We do. Okay, I don't know if you guys want to put on gloves and feel, but we do have, there it is. So see these two little nubbins here? Those are actually the backs of the hyoid. So the hyoid like connects the tongue, right, to it. and then the larynx to it from below. So it sort of suspends the larynx on the tongue. So this little C-shaped piece of bone is going to be the hyoid. Let me see if I can, if anybody wants to come and feel it, put gloves on and please do so. Yeah, do it. Do it. All right. So I'm going to cut. I think I'm going to cut above the hyoid maybe. Yeah, there we go. So this is what you would get normally in a laryngectomy. you get the hyoid, the larynx, probably not the esophagus. All right. You sometimes get thyroid in the laryngectomy. If the tumor is more unilateral, you may just get one lobe. If it's a big diffuse bilateral tumor, you may get both lobes of thyroid, but that's more for sort of marginal, issues. Okay, so what I'm going to do is I'm going to take the thyroid off as best as I can, and then we'll deal with that. So what should we do next? Should we do more anatomy? Should we do grossing of thyroid? Should we do grossing of tongue ellipse? Does anybody have any preferences? I'm at your command. Okay. Sorry, I'm making little nicks in the thyroid. That's okay. It'll deal. Okay, perfect. Okay. So we'll put the thyroid aside for now if you guys want to see a tongue ellipse. Okay. So we talked earlier, or we talked in the anatomy histology lesson about how the extrinsic tongue muscles are, how are they different from the intrinsic tongue muscles? Who remembers? Correct. So I wonder if we could take sections. On, right? For normal. I think we should. It's already fixed. Anybody online have questions? No. I'm just going to cut down the midline here since it's already happened. All right, awesome. So you could almost start to imagine maybe that these larger extrinsic tongue muscles that we cut through are sort of starting to radiate in this direction. It's a little bit hard to see, but okay. What are we gonna do with the ellipse? Okay, so remember that on your tongue, you have the dorsal surface, you have the lateral borders, right? You have the ventral surface, you have the anterior portion, and you have the posterior or base of tongue portion. So what mucosa is the ventral tongue in continuity with? As you go forward towards the mandible. Anybody? Floor of mouth. Yeah, right. Okay. So this mucosa was cut here, the junction between the ventral tongue and the floor of mouth. So if you're dealing with a floor of mouth specimen, you may see that, mandible here, right? Floor of mouth, ventral tongue. Does that make sense? It's all in continuity. Okay. So this is what ventral tongue mucosa is. It's not that much. Most of our mucosa is on the dorsal tongue, sometimes on the lateral borders. Okay. So when you're dealing with any sort of ellipse, let's just cut this off here. And let's pretend like we don't have lateral border, like we don't have floor, like we don't have tip. Okay, so when you're getting a specimen in the gross room, it may be something like this, right? A general tongue ellipse. Of course, it's not going to be this nice and square. It's going to be a little raggedy because they're taking it out in vivo, right? But you're going to have directionality. So you're going to have anterior, you're gonna have posterior, you're gonna have, depending on whether you're midline of the tongue, you're gonna have right and left, or if you're on one side of the tongue, you're gonna have relatively more lateral and relatively more medial or towards the midline, okay? So naming of tongue is going to depend on where it comes from, okay? If it's midline, if it's lateral, if it's dorsal, if it's lateral border, or if it's ventral, right? So just, you have to picture, sorry, you have to picture in three-dimensional space where it's coming from, okay? But most ellipses, whether they be skin or mucosa, can be sort of construed as boxes. And so if you don't know how something is anatomically oriented and they put a suture at 12 o'clock, cool, you can use a clock face. So, 12, 3, 6, 9. But if you do know how something is anatomically oriented, I prefer you to use the anatomic nomenclature because that makes it much more easy to know where in the patient you're dealing with, right? So don't be like, I'm going to redesignate anterior 12. Please just designate anterior, anterior, and posterior, posterior, medial, and lateral, okay? Unless you have absolutely no idea where it's coming from, then you can use the suture designation that they have given you. Okay, otherwise use anatomic terminology. Generally when we ink these, we only tend to do 2 colors because there are sort of structural planes that will let us know where we are. So if you think about how we're going to section this, we're going to ink it longitudinal, parallel to the long axis, and we're going to section it perpendicular to the long axis, right? So you always, based on ink colors, have your, I'm just going to say right versus left, okay? In your sections, you're going to have right versus left based on color. You're going to have directionality of anterior to posterior in how you submit your slices, okay? And you're going to have peripheral versus deep based on the turning of the corner, right? So, if your tissue is right up near mucosa, that's a perpendicular, margin. If your tissue is anti-mucosa, that's a deep margin. So we know directionality from cassette submission. We know right and left from color, and we know peripheral from deep based on corners. Does that make sense? Okay. So rather than ink it now to save time, we're just going to write imagine that you have, unless you want me to do it, I don't care. Are you guys good? You want me to do it? Ink it or not ink it? Let's ink it. Oh, sorry, everything back there I just said. We'll be really, really good. I promise. Okay. So because black is nasty and mean and sinister, generally we do left-sided things black. Okay, so left side, I think this goes for prostate, this goes for thyroid. So let's do left black and right blue, just like we do sky superior blue and earth inferior green. We do sinister black and whoops, that's cute, Dexter blue. Okay. All right, so we meet the 2 colors in the middle of the anterior. We meet the 2 colors in the midline of the deep. I promise that's black and that's blue. And then we meet the 2 colors in the midline of the posterior with our sides being covered. I guess I got that wrong. I think that was anterior. Yes, that was anterior. Left, right, anterior, posterior. Good? Good. Okay. Vinegar. Why do we use vinegar? Making a lengua taco? No, okay, because it helps the ink stick. So be generous with your vinegar, be generous with your squeezing, just be generous. I don't know. I like vinegar, both for specimens and for eating. We can get into that another day. Saturday, when you guys come over, we'll talk about this. All right. Okay, so yep, anterior, posterior, left sinister, right blue. Okay. All right. So the one critical thing that I'm going to say, not only for how to gross these, post fixation, but also when you get a tongue excision for frozen, you want to treat it as if you're going to be grossing it. So those of you who've gotten these for frozen, imagine, right? If this is where it was in the patient, right? This is sort of where I've cut it all off now, but it's a good example of, okay, where was this? It was, I'm just gonna lay it on its side, right? It was here, right? So they've taken this thing out and they're saying, I wanna know what the status of the deep margin is for tumor. And then I want my permanent sections. And then what they're doing is they're sending a bunch of little strips from around where they took this out. That causes sometimes some confusion in the terminology. These are called tumor bed margins, okay? So on the synoptic reporting for tongue cancers and for mucosal cancers, we have the main specimen, we have the tumor bed, quote unquote, margins. So this hole is where the tumor was. This is referred to as the tumor bed. And so what they're doing is they're taking from this hole in the patient, they're taking another ellipse of mucosa like this, and they're saying, freeze that, that's my margin, okay? So you may not know which direction this is in the patient. You just know that it's an ellipse, a strip of mucosa. So this is an en face margin. You freeze it and that's it, okay? That's a quote unquote tumor bed margin. They'll do the same here. They'll go around the entire, right? They'll go around the entire thing that they just took out and give you 360, okay? What they won't do, okay, let me rephrase that. Sometimes they'll take a tiny little piece of muscle and they'll be like, that's my deep margin, okay? But think about it. Where on the main specimen does this come from on the deep margin? One has absolutely no idea, okay? Unless they shave the entire like muscular bed of the tongue, which they generally don't. So that's why they send this for deep margin. So when they say deep, they mean deep and perpendicular, because if they're sending you only a strip like this of the mucosa and the ellipse is this deep, we also need to evaluate this periphery here. Does that make sense? And certainly the deep here. Does that all make sense? Because I know these are confusing, not only for us, but there's tons of literature on how this is just a very haphazard practice. Therefore, examining the main specimen is going to be your best way of accuracy for margins. So you're not going to want to be like, oh, I feel tumor here, let me just whack into it and take a piece. Nope. You're going to want to gross this during the time of frozen as if you were grossing it for permanent. So regardless of how I tell you now, this is what you will be doing, whether it be frozen or permanent. So our anterior and our posterior margins are going to come off. In this size of a specimen, we want to do them perpendicularly, right? So we see the tumor approach the edge rather than just a little strip of en face, because we already have the en face from the tumor bed. And we're going to serially section it fully and do again perpendicular at the posterior. So I often tell people that when you're doing perpendicular margins, don't make it super tight, because then think about it. When you're going to cut these perpendicularly, they're going to like flop over and histology is going to have a hard time embedding them. So it's okay, take it a little deeper. Like, yes, that is way too thick for one of your routine midsection slices, but it's okay because you're going to be subsequently slicing this way, right? So we're going to take this guy a little bit thicker than we might normally do. All right, lay that aside as our anterior. We're going to keep doing. I know this is a fixed specimen now, so it's a lot easier to cut. But if you are in the gross room for a frozen and you get something like this and it's really juicy and wobbly, I allow you, we can do this if you want at some point, only if it's a fresh specimen, not if it's a fixed specimen. I will allow you to lightly immerse it in liquid nitrogen to firm it up a little bit and then serially section it, because that allows you to get really nice thin sections through the tissue. Don't ever immerse a fixed specimen in liquid nitrogen, because the formalin will crystallize and blow everything out. But if it's fresh or only saline, you're fine. Okay, so now we have our slices in order, right, from anterior all the way to posterior. And we would want to evaluate now for where the tumor is, of course. So let me get rid of this, put down a nice white background. Okay, so if the tumor is present in many of these slices, we have to evaluate the closest to the left sinister, right? The closest to the right blue, and the closest to the deep. Remember, the deep has a left black aspect and a right blue aspect, okay? So all three of those sides we have to evaluate on these slices. And then if you see tumor here in these, what do we got to do? We got to look at these two, okay? Right, so now we're going to section. So this is the cut that we made, right? So this is the pathologist's cut. This is the surgeon's cut. It's got ink on it. So here we're going to section these perpendicularly. Oops, sorry, that's a little wonky. All right, 1, 2, 3, 4, 5. Okay, so now we have the perpendicularly sectioned posterior margin that we can now evaluate the approach of the tumor to that posterior margin. And this is what I want your sections on the slide to look like, right? I want to see your cut. I want to see the deep margin inked. I want to see the posterior margin inked, and I want to see that ink touching the mucosa, and then I want to see the mucosal, right? So you can evaluate how close the in situ comes to the ink and how close the invasive comes to the soft tissue ink. Okay, does that all make sense? So if you see nothing here, don't have to freeze it. You see something approach here, arguably you want to freeze that slice too, yeah? So then we do the same thing with the anterior, right? So your cut, surgeon's cut, perpendicular. Okay. 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 So same thing here. Evaluate and freeze as necessary. This process is what you do, as I said, at the time of frozen and when you're sectioning for permanent, okay? Who has questions or comments? Okay. See that red? See that brown? So, you know, things I can't not talk about cooking. So, right, things fix like they cook, right? So when you sear a steak or whatever, it's brown on the outside and rare in the middle. Same thing happens with fixation, right? It's brown on the outside and red in the middle. This might be delicious for your steak, but it's not delicious for your histologic sections. So if something is underfixed, i.e. if it's relatively red or pink compared to the surrounding tissue, you may want to let these additionally fix until they become completely brown before you submit them for histology processing, because the amount of formalin that they see in histology is much less than what they would probably need to actually fully fix. So don't be afraid to just like delay to the next pickup or whatever. If it's red, it's really red, okay? So things that are muscular, that are red, things that are just bloody and hemorrhagic need extra fixation. So always keep that in mind, because your sections, when we sign out together, we'll see artifacts of poor sectioning that tends to look milky, like watery or like yucky, okay? Questions, comments? What else do we have to say about tongue? All right, so this is the simplest process for a tonguey lips, for a skinny lips. Okay, and most tongue or mucosal excisions can be conceptualized as sort of glorified skin ellipses. So say you have a, you know, a piece of gingival mucosa, right? So mucosa on the bone, but maybe you have some bone under it. Well, you can still take the same concept and treat it as sort of a glorified mucosal ellipse with some bone stuck under it, right? So just, we can use this process to simplify many things. Okay, comments, questions? We good? We good on tongue? All right, should we do thyroid, larynx?
Yeah, we've got 15
Okay.
minutes.
Let's do thyroid because larynx is a little complicated. All right, so thyroid, we saw where it sits, right? Sits sort of anterior to the cricoid / thyroid cartilage / trachea in the neck. The anterior surface is convex. The posterior surface tends to be concave. And so even if this comes as a hemi or a lobe, you can generally make out the curvature, right? The superior poles are pointed, the inferior poles are rounded, and the right and left lobes are connected by an isthmus. Sometimes they'll take, this is lovely, we have strap muscles on the front of the thyroid gland. So usually you probably won't get many strap muscles because they try to preserve them in the patient. If there's thought to be clinical extrathyroidal extension of tumor into the strap muscles, they may take some of those, and those can also help for your orientation and for your sort of determination of cancer staging. Okay. So same as with the tongue, I won't do it now because you've seen me ink, right? We do left black and right blue. Some institutions that you may go out to ink differentially the anterior and the posterior surface. So like posterior black, you know, anterior left orange, anterior right blue or whatever. The reason that we don't do that here is because in the case of thyroid, if you have a positive margin, for example, on a tumor, they're not going back like they are on the tongue. They're going back. So they want to know exactly along that tongue, like where that positive margin was. On the thyroid, they get their disease macroscopically. If there's a positive microscopic margin, the patient may get radioactive iodine. All right. So exactly knowing what's anterior, what's posterior, whatever, it's not going to help them for first reoperation. What it may help with is things like if there's extrathyroidal extension of tumor, does it extend anteriorly into the strap muscles, or does it extend posteriorly into the trachea, etc.? Usually those things are documented clinically, and there's muscle, right? So on the anterior surface, there's strap muscle, you'll see it. On the posterior surface, there's really not muscle. There's going to be your kind of perichondrial plane, and then your cartilage. So you have a number of ways to determine what's anterior and posterior. So I don't find that inking it differentially adds anything, but some places do that, which is totally fine for those reasons. Isthmus. So if you have an isthmus that is relatively sort of long, we tend to ink that a different color, orange. If you have an isthmus that's kind of really narrow, you may not need to ink that a separate color, but use your best judgment. I'm fine either way. Let me remove the strap muscle here so we can sort of see where our, so here we go. So once you get rid of the muscle, then the sort of inferior border starts to become clear, and you could see sort of where the isthmus lies. All right, so in this case, we may consider sort of this, the isthmus, this the right, and this the left. And so you have different ways of sectioning it, depending on if the isthmus is really narrow or if the isthmus is kind of broad like this. The manual suggests, pretend I've inked it, okay. The manual suggests that you could sort of amputate the right, amputate the left, and then do the right and left perpendicularly, and do the isthmus in this plane. That is fine. If you have a nodule that sort of spans the isthmus and one of the lower lobes, you may not want to dissociate it like that. You may want to just keep it intact and do all of your sections in one plane. All right, so you don't have half of your nodule over here sectioned in one direction and half of your nodule over here sectioned in the other. Does that make sense? So a lot of this is judgment, so the thing that I like to, emphasize is that, yes, there's a formula. Every specimen is unique and you have to use your judgment. If something doesn't make sense to you, just ask. Okay, so for now we have an isthmus, we have a right, and we have a left. There are two possible ways to do lobes. This, of course, is a total thyroid. So sometimes you get a total thyroidectomy. Sometimes you get a total thyroidectomy in two containers, right and left. In that case, this margin, this cut that they made between the isthmus and one of the lobes is not a true patient margin, right? This is an artifactual surgical cut. And sometimes you actually only get one, right? So then this really is a true margin. Regardless, you should, just for practice and security, you should always ink the cut area at the level of the isthmus a different color. And I think we say, again, orange, right? So if you have a total thyroidectomy, the orange will be around the periphery of the isthmus, okay? If you have a hemithyroidectomy, the orange will only be the cut surface, because you want to know that exactly this surface is still in continuity with the patient, right? Just like the periphery is still in continuity with the patient, okay? Does that all make sense? So we don't want to bleed, we don't necessarily want to bleed too much of that orange ink over, because I want to know exactly that the thyroid tissue is in continuity with the other thyroid tissue in the patient. The reason for that is, say a patient does have a tumor that's here, and there's a positive margin here. Well, if there's a positive margin here in continuity with the thyroid tissue, that may mean that they can go back. In this case, they may actually go back and complete the patient's thyroidectomy. If there's a positive margin at the periphery here, that case, they're generally not going to go back and take any more. Okay, so that is the one instance in which the location of the margin matters, whether it's peripheral or cut thyroid tissue. Okay, that's the one point where it may matter. All right, so once you have your lobes, there are two ways to do it. So, you know, the manual says cut superiorly to inferiorly, or inferiorly to superiorly, whatever, transversely. That's cool. If you think about, though, picture on the inside of this thyroid, there's a nodule. And say you, can I draw here? Yes. Say you want to look at the capsule of this nodule. Well, the best way to look at the capsule of the nodule in the thyroid gland is to treat the poles of the capsule perpendicularly, like you would treat the perpendicular ellipses of mucosa, right? So how are we going to do that? How are we going to know where the nodule begins and ends? One way to do that is to, oh yeah, there's my cut isthmus margin. One way to do that is to longitudinally bisect the lobe, expose it, look for where the nodule is. So, you know, we're going to pretend that a nodule is somewhere in here, right? We're going to say, okay, right, I'm going to perpendicularly section it right up until I get to the tip of that nodule. Let's say the tip is right here. Then I'm going to take a little bit of a longer strip, and then I'm going to section this perpendicularly, right? Because then we'll be able to see the perpendicular approach of the capsule and whether there's capsular invasion. So same thing, I'm going to walk my way through the nodule in slices, slices, slices. Okay, oops, then the nodule ends here. All right, then I'm again going to do the same thing. I'm going to take a longer slice and section it this way. Does that make sense? Why you might want to do it that way? So you're basically putting like a skin ellipse or whatever inside the thyroid gland, okay? Because your most important diagnosis for thyroid follicular neoplasms is invasion through the capsule. And if you see the capsule on FOSS like this, it's not going to be helpful, right? So you want to see it cut perpendicularly. Okay. The other option, if you have something that's pretty much already a known cancer or a benign thyroid like Hashimoto's, Graves', whatever, you can totally just do through and through superior to inferior sectioning without this longitudinal intermediary. Okay, does that make sense? So this is the standard, standard approach. This sometimes in the literature is referred to as the modified transverse vertical approach, right? Because you're kind of doing both. Okay. What else can I tell you about thyroid? What did I miss?
Pyramidal lobe.
Yes. So the pyramidal lobe is not present in this case, but if you remember where the isthmus was, let's just piece this guy back together, right? This guy was here and here, and this guy was here. The pyramidal lobe would be kind of poking up superiorly from the isthmus. And so sometimes it's like really narrow, right? It's like really thin and narrow, maybe like 2 toothpicks or something. So what you could do with the pyramidal lobe, if it's here along with the isthmus and you want to section it this way and just sort of bisect it, that's fine. Some people, if it's thick, have sectioned it this way. It's all, you know, everything depends on the anatomy of the case, but this is where the pyramidal lobe would be. You also may or may not see lymph nodes and or parathyroid glands around the lobe. So generally they tend to be in the central neck, sort of around the isthmus. But you can have little things popping out everywhere. So just be mindful if you see little nubbins that look a little odd, consider that they could be lymph nodes. Try to submit those separately. Sometimes they end up being lymph nodes and sometimes they just end up being little exophytic bits of thyroid. That's fine. We'll be able to tell on the histology. What else? Are we on time?
About 5 minutes, I think.
Okay. Something different? Something else on thyroid? Larry, questions from the peanut gallery?
Yeah, there was
If the
one.
nodule is very small, can we just do the standard approach?
Yeah.
It would be very different.
Yes, absolutely, absolutely. So this would be more for something larger and something that was maybe like a follicular neoplasm or floss or something like FNA. If you can always give me a call, right? Always give me a call. The size of the nodules are available usually via ultrasound reports. So they'll give you an indication of what you're dealing with. So if it's like 1.5 centimeters, great point. You probably just want to do the regular direction. If it's like 4, 3, 5, maybe consider, oh, maybe I'll do that. Yeah, for sure.
There's a question about the intrinsic, extrinsic tongue muscles, I think.
Yeah.
I don't know, like, I guess Jasmine couldn't hear a response. I don't remember exactly what
Oh,
question.
the question was they're different because the intrinsic tongue muscles are tridirectional. So basically longitudinal, transverse, and this way. But the extrinsic tongue muscles, like the genioglossus, etc., are unidirectional. So they would all kind of converge in this direction. Is that what she was not getting? Hopefully, okay. I hope that's what you want.
Did you mention about how you can tell the landmarks you can tell on before you cut into the thyroid, which is anterior and posterior? There's like a notch and there's like smoothness or something.
We talked about the convexity and the concavity. So generally convex on the anterior surface and generally more concave on the posterior surface. But if you have a very nodular, bulky gland, it may be a little bit more challenging. You can even see here, right, in this cut section, which we took this way, this is the anterior, sort of more convex, and the posterior, actually there, sorry, a little bit more of a concavity. Okay. All right, that's just muscle. Okay. What else? Okay.
All right.
We can save this for another time if you'd like.
Sure.
I think it might be nice to do a larynx that's not a cancer case. So we can schedule another session, but hopefully that helped with some basics of things that we see very often. Always call us. We love to come and look at things with you.
Okay.
Thanks.
All right. Thanks. All right. Bye, everyone.